So, welcome to this episode of Menopause Conversations. My name is Amantha King. I'm a workplace menopause consultant and executive coach, and I'm delighted to have my wonderful guest, Dr. Sarah Chalhoub. Hello, Sarah, how are you?
Hello, Amantha. Thank you so much for having me. I'm very well, thanks.
Oh, great. That's brilliant. So it's a pleasure. So I met Sarah very briefly via a post that I saw that she'd written around her research. And I thought, oh my goodness, we definitely need to have this conversation. So we sort of titled this podcast Sex, Silence and Selfhood, Reclaiming Intimacy During Menopause. And I think this is just one of those corners of the menopause room that we don't shine a light into, but Sarah has. So thank goodness for that. Let me tell you a little bit about Sarah, and then she's going to tell you a lot more about herself. So we've created a reflective and what I and Sarah both believe is a necessary conversation. Sarah's an academic, clinical researcher whose work spans women's mental health, trauma, and sexual well-being, and she's also been a midwife. So that's hugely helpful, isn't it? It tells us a lot about her understanding of that intimate process that we go through. Her most recent cross-national research explores how psychological risk intersects with sexual changes for women in midlife, revealing powerful insights about vulnerability, silence, and resilience. So I can't wait to dive into this. So welcome, Sarah. Thanks so much for being here. So if it's okay, would you mind just telling the listeners and the viewers a little bit about you and how it is you find yourself in 2025 completing research and an imminent book around this topic? So over to you.
Thank you so much. Yeah, so I've been a midwife now for over 24 years. Always felt really privileged to be part of women's journey and really have witnessed that transformational process if women are given the time and the space to have those meaningful conversations in a trusted space. Um, So, given having been given this opportunity, I think at a time in my career where I was really ready for a change, being given, never really, I guess, as well, thinking I was clever enough to do a PhD, was given this opportunity to look at menopause and sexual well-being. And I just thought, what a great opportunity to transfer my skills and my experiences with women in those deeply intimate periods of their lives to menopause and sexual well-being. And you're right, it's not something that's been looked at in great detail in the past. So it's really, really important.
Yeah, absolutely. And so we've got some questions, but I suppose, and I did say to you we would go off piece, but I was just wondering, why do you think it is that we don't talk about it? I mean, intimacy is a huge part of relationships. We know that it can really impact couples, same-sex couples, heterosexual couples, our relationship with ourselves, actually, in terms of our own intimacy. Why do you think haven't been talking about it up until now? What are the barriers?
So I think it's multidimensional, and it intersects with religion and those feelings of guilt to talk about it. If you look about the historical context of sex and women, you look at women who were good wives, who were witches, midwives in brackets, who were
Yeah,
burnt at the stakes,
yeah.
and or dirty prostitutes who it was fine for men to use, but women were completely, discredited. So there was three areas. So sex had always been seen as kind of a dirty thing, a guilt-ridden thing, something that wasn't discussed in public. Um, it was seen as a reproductive process rather than something that was of shared pleasure, unity, and a biological process which really enhances both your biological and psychosocial functioning, your confidence, your self-worth, your endorphins, which are ignited when you have a pleasurable sexual experience.
Yeah, wow. I mean, this is just brilliant. So let's get into these questions then. So, I mean,
Yeah.
your research is huge. It spans 9 countries, if I'm correct. Tell me what stood out most to you about the way women experience those sexual changes, specifically during menopause, and
Yeah.
across those different cultural contexts that you very kindly just shared with us. What did you notice? What did you find out?
So the first study, yes, looked at literature and research from 9 countries. And I think, you go in to this research with your own personal biases as well. So you my family are Lebanese, and so you would, that cultural awareness that sex and marriage are seen very differently. The divorce rate is much less. The, conformity to certain ways of living is different from in the Western countries. So my assumptions already were placed that these could be different.
Mm.
But actually, what I found was so women in different cultures experience physical menopause symptoms, which had been shown in previous research. So things like hot flushes are experienced differently in certain cultures. Headaches are more common, and hot flushes are more common in Black African communities, for example. Um, but the and the changes in desire are greater in, so you have a less desire in like the UK and America, but in the European countries that's higher than in the UK.
Okay.
So there's difference in those physical symptoms, and you could possibly look at that attributing from kind of that association of menopause as part of, you know, the illness, the medicalization of menopause, and thinking about how
Mm.
women translate those symptoms into the system and the culture to get the support they need, maybe.
Yes.
So there's lots more that needs to be done in the research area about these, but looking at that association about, what really stood out to me is that despite those cultural differences, despite those religious um, you know, differences, and they were huge. Um, that actually the one thing that was universal was this sense of duty, this silence around sex and describing their symptoms. And that was both with intimate partners and with their medical practitioners or with kind of women friends. There
Mm.
was a real they were unable to communicate that with confidence or with clarity without embarrassment or shame, and this sense of duty to perform sexual acts for their partners. And I would like to say this isn't all women that, but the majority of women describe this sense of duty. They were in heterosexual relationships, and this was about kind of that marriage lock-in, where they felt that to be a good wife or to be a good woman, they needed to continue to have sex to prevent their partner having an affair or to preserve their femininity for their partner and to pleasure them as partners rather than for themselves. So they would do this, despite the discomfort they were in or the lack of desire that they had.
Wow. And I know you say that's in heterosexual couples. I can just imagine, because in the work that we do, what that must be like then in a same-sex couple. Where do we have any evidence for that for
So for
them?
same-sex couples, it was profoundly different actually, that
Okay.
they experienced much more respectful sexual relationships where
Mm.
they adapted, they asked how it felt, they were much more in tune with what how they would navigate this period of their lives in a much more equal way.
So talking about it, I would imagine, is really powerful. That communication piece and that shared
Yeah.
understanding and negotiation and dialogue, all of
Yes.
those things that are really, really profound. Yeah, that's so
Yeah.
interesting, isn't it?
Mm.
I was in a prison last week,
Yeah.
Sarah,
Yeah.
and it was like really profound. I mean, just how many women spoke about libido, actually?
Yeah.
Interestingly, I found it hugely
Yeah.
interesting. You'd just think, well, hang on a minute, you're incarcerated. Why is that even important? It is
Yeah.
important to people. Um,
Yeah.
and um, and I just found the whole medicalization of menopause. It's almost like we just go straight into medicalizing it. We don't talk about the social norms. We don't talk about the cultural variances. We don't talk about how it feels for you. It's like let's just treat all the symptoms. Let's and that is important. but we can't take, we can't miss out all these other things. And, and again, I saw huge degrees of discomfort and degrees of comfort talking about intimate areas of their body, talking about
Yeah,
what's painful, what hurts, what they want support with. So I think we have a lot of work to do, don't we, to sort of redress this balance to say that intimacy is important, full stop, whether that's with yourself, sharing that with a partner, and
yeah,
actually this whole context around duty, the whole
yeah,
shame, the shaming element, the preservation. I just wrote one word down, preservation. It's almost like
yeah,
self-preservation, isn't it? Preservation of the
yes,
relationship, preserve this, preserve at all cost.
yes,
So I suppose the question that leads nicely to that is that you talk about women who thrive during this transition as having a strong set of life and relational resources. Can you share what some of those resources are? Because I'm sure that would be hugely helpful to people listening, and and how women can build on them earlier in their lives rather than having to go, oh my gosh, like we both said before we joined the call, there's a lot going on in our lives. Having to think about this as well, it's just like that could be a full-time job. So how can people
of
prepare
course.
themselves?
So what I found in the first study when I looked at the data was that there seemed to be a set of kind of resources which women had built a toolbox almost that they could then reach for and harness that when they were going through the menopause. Um, One of those was meaningful connections, which is, widely researched as a kind of a stabilizer in transitional periods in your life. So
Yeah.
having grounded the relationship grounded in humor, kindness, communication, and equality. And so that transpired, for example, in housework tasks, for example, so
Okay.
that partnerships were shared, that the childcare was more equal, that respect for each other then gave more time, I guess, as well for
Hmm.
cuddles and, watching TV together, having a walk together because they had more time together. Um, but just that mutual respect as well. Um, so sex then became about expression and not expectation. So it was about them being able to communicate that love and respect for each other rather than, okay, I feel like I want sex now, and therefore that's your duty. So the second was that women had built a level of psychological capital. And I mean, we might talk about this later, but
Yeah.
psychological capital is something that's usually seen in business arenas where hope, resilience, efficacy, and optimism, like the HERO acronym,
Yeah.
that women have built those resources and which has made them more adaptable, more confident to seek help, more capable of reframing the sexual changes as challenges rather than losses.
Yes.
So they have been able to build those. Now that the psychological capital element is a really interesting thing because we know that 40% of our psychological capital is about development, so that we have
Okay.
40% capacity to develop our thought and our HERO acronym. So we have 40% capacity to build our hope, to build our efficacy, to build our resilience and our optimism, which really gave me hope because some of these findings were really dark, and
Yes.
really kind of cut deep because I think working with women for over 24 years, of course, I see patterns of abuse and discrimination, but to know how devastating this was to women
Hmm.
at this period of their life, and because there was such a gap in our knowledge around actually we we know that the highest rate of suicide across the female lifespan is between women of 45 and 64 years of age. And that's been consistent over the last few years.
Hmm.
So to be able to have the opportunity to give women these skills, to help them, support them, give them the space to hold that and let them build these resources would be an amazing thing. And finally, really for them, I guess that psychological capital also came to play because if they could build that, optimism and efficacy, they were able then to access credible information, to seek out support from other women as well. So they had confidence to go and join groups and talk about their menopause,
Yes.
talk to professionals with evidence-based information. And that didn't really and I think again something that came from my midwifery experience was that this is not a cultural or a um like a socio-economic divide. This
No.
is women across the board. So you could have
Interesting.
somebody, an executive level CEO who is navigating the same
Yes.
issues as somebody who is, a stay-at-home mum who who hasn't got a lot, you know. So their opportunities to ask for help, to seek confidently that information, was really beneficial for these women.
Oh, that's so brilliant. I've got so much I want to just sort of come back to you on that. Thank you for sharing that. That's really, really powerful because, all of those things in my executive performance coaching, those are all
Yeah,
strengths.
yeah, yeah,
And that's what's brilliant. That's why I absolutely love what you just said because it's opportunity, isn't it? We need businesses, workplaces to be helping people either boost those skills, reclaim those skills,
yeah,
develop them, whatever you want to call it. But there is a responsibility there. And I am delighted that menopause is part of workplace existence now. From 2027,
yeah,
it's going to be mandatory that every business with over 250 employees actually has menopause action plans. So everything you're talking about is highly relevant, Sarah. So
yeah,
and I really really like that. And I coming back to the meaningful connections. I'm a great believer if you can't find what you're looking for, go create it. So I live in Devon. We don't have much funding down here, and we certainly don't have menopause groups that we can just trot along to because it's a very rural area. So I created my own group. It's called the Empowered Pause, and we meet once a month. And I can honestly tell you, I don't have a lot of time for charity work, but that is what I give my free time to. And one of
yeah.
the ladies emailed me recently because I had to have a month off because I hurt my foot. And she said, I can't tell you what a lifeline it is for me, Amantha, to come to these
Uh,
groups.
yeah,
And it's those powerful, just almost fleeting statements that just really tell you everything about what that means to people. And these women come together, we laugh a lot, we laugh at ourselves, we laugh at
yeah,
life, we just laugh.
yeah,
But we also weave throughout that knowledge, experience. It's very validating. And the more I research relationships, the more I understand how important proximity is. If you don't have good proximity, like
yeah,
closeness,
yeah,
it can be devastating. And I don't know about you, Sarah, but it's almost like, when we were raising our children, it's very, very intense. And there's no end of people we could connect with when they're little. But actually,
yeah,
as you go through those teenage years, it all starts to fall away. And it's just at that time when we start to feel like actually we could do with more of that connection. Obviously, it's the right connection. I have found, and I've said very publicly, I've lost a number of significant what I thought were lifelong friendships, but that's because actually you wake up to what you value, what's important to you, what do you have time for, what don't you have time for. So I think these are all valuable things that you're absolutely. I love what you've found here, which is that we need to invest, make the time, not deprioritize it, but make the time to invest in those relationships because 40% capacity to build hope, you
yeah,
know, that's brilliant. And I like that. I like that hero acronym.
yeah,
That's a really good one. I just
yeah,
see if you see me writing, I'm literally scribbling all over your notes. So this
yeah,
is brilliant. So okay, so we banked that. So in summary, what we're saying is socioeconomically, it doesn't matter where you find yourself in the world, this is pretty much a universal experience that we go through this. So we need to wake up and
yes,
start doing something about it and supporting those people in our communities who maybe don't have, like you said, that capacity. We need to reach out, look around us, bring people together. So your findings also highlight and I did find this quite hard to read, but I think it's necessary. Your
Mm,
findings highlighted that many heterosexual women feel a sense of sexual obligation, which you described before, even when they're in physical pain. So, what does that say
yeah,
about gendered expectations? So for the men, other partners watching this, and believe
yeah,
me, although we don't see many men comment when this video goes out, I have it on absolute good standing. A lot of
yeah.
men do watch these videos. So, what does it say about gendered expectation in relationships, and how can we start unpicking that narrative?
I think it was one of the most striking and one of the most painful things that I found across this research, that women do not many women do not experience that mutual pleasure that they perform for their partners.
Hmm.
And I think, just as I mentioned earlier, that historical context, thinking about, women at menopause age were not that long ago given electric shock treatment and seen as crazy, given hysterectomies to remove the hysteria. Um, and, I think that historical context, that social narrative, the sexual scripts we use about dysfunction, about, we are broken women. So, and when our sexual desire is maybe less, or we have, you know, symptoms of kind of a dry vagina, or that we don't communicate that. And I think there was two things with this sense of duty that I found. So one was not about kind of that coercion, that abusive situation. One was about, actually, I love this person. I value my marriage, my relationship, and I used to really enjoy sex. It was a big part of my life. Therefore, I will try in every element to keep that going, but without communicating that actually this is really painful. Could we try something else?
Mm.
Not, having that confidence knocked out of us, kind of thing, in menopause, that we are unable to confidently give consent. And do we actually know what consent means within a relationship? We've been taught that, again, those vows to obey and to honor, and we need to be having those conversations. This is not about male hating. This is not about saying men are
No,
bad. Men
no.
are not educated. We don't teach our boys. We don't teach our, you know, slightly off piece here, but I've got a teenage boy, and teaching him about actually respect, teaching him about how the female body works. What is an orgasm? What are the anatomy of the female, reproductive system? They need to know this.
Mm.
It's not just about a diagram and labeling things. We need to empower boys as well as our girls to know their body.
Yes.
I don't think girls really know their body
Oh my
truly.
God, no, Sarah, they absolutely don't. Like, if I've got a 3D model of a vulva,
Yeah.
and which mortifies most people.
Yeah.
It doesn't
No.
embarrass me at all. I'll take it out
Yeah.
anywhere, time or place, and I have been known
Yeah.
to do that. And the reality is, we do need to know that because,
Mm.
penetration is not. For most women, penetrative sex does not result in an orgasm. For most
Yeah.
women, because we know the clitoris is highly populated with nerve endings and things like this.
Yeah.
So the reality is you do need to know what you're doing. And then we're up against social media, aren't we? We're up against sites like OnlyFans and goodness knows
Yeah.
what else, and
Yeah.
porn that
Porn. Yeah.
basically sort of says this is what intimacy is like. And it's like, hey, newsflash for everybody, it absolutely isn't. And I would like to acknowledge that there are some other sites where it is loving relationships being played out and people can
Yes.
watch that type of thing. There are various things.
Yes.
But we've got no control over where this information is coming from. So we, as parents, we absolutely do. We can't sit behind it's embarrassing or I shouldn't be having the conversation. If not you, who? Who
Who?
else
Yeah.
is going to have this conversation? And there are a lot of people doing really great stuff. I would just like to signpost people like
Yes.
Diane Dancebrink, one of the grassroots supporters. Menopause is spoken about in schools, in secondary education. It is spoken about now in medical schools where it wasn't once before. But I think you're right. I think we need to sort of expand this whole consent conversation, and not just for our young people, by the way. I think actually for everybody, we need to update. So in your words, in terms of consent, how can we sort of understand this in the context of menopause? So here we are in a loving relationship, and I'm really glad that you went there first. Um, how can we even broach that? Like, because maybe you are of that generation where it's a bit embarrassing. Like, I know she's got all her lady stuff in that cupboard. I know,
Yeah.
yeah,
Yeah.
yeah. I'm happy to go and put it in there, but that's about as far as it goes.
Yeah.
And I know we love each other, and I know, but actually things are changing. So is it me? I'm changing. So I'm talking here as the partners. Um,
Yeah.
how can we sort of move into this place whereby it's still loving, it's still consensual, and it's still caring? What can we help partners with?
I think for women to use I statements. So, I love it when you touch me in that way.
Yeah.
I really loved that experience when we did that together. And it might have been just a long walk or a cuddle and a kiss on the neck when you were, cooking or something, but
Yeah.
explaining and expressing in short. So it doesn't need to be directly and immediately into, I don't want to have intercourse tonight. It's like, I
Yes.
love you when you touch me like that. Can we cuddle in bed tonight? Um, I'm feeling and expressing that you're feeling really vulnerable, that there's changes going on in my body. And one of the ways I navigate tricky conversations with people, because I do mentor young women through the Girls Network as well.
Oh,
Um,
fantastic.
yeah, so and talking to them about healthy relationships. I think, we talk about biology very frankly, don't we? We've got a
Yes.
digestive system. Therefore, why aren't we talking about sex like that? And I think to break that down with women, to then express to their partners, look, we both grew up in a society where, you know, um, sex was talked about in a guilty way. Now, our relationship has a foundation of really great sex in the past. Now things are changing for me at the moment. That doesn't mean it's over, but it means that we need to adapt and change. And maybe that'll be exciting to learn that together. But you have to be patient with me. And I think most men would be devastated to hear that women were lying back and pretending to have a nice time and then bleeding afterwards. I think most men would be horrified. Um,
Yes.
and so giving them those skills and actually just educating them that this is a thing,
Yeah.
you know, that these changes happen because of hormonal changes. That there's medical terms, so, vaginal atrophy,
Yes.
that changing of those skin cells in and around the vagina and vulva, which can make it really sore, but these are things that can help. And I don't want to just go straight to the lube solution. It needs to be about that activating those endorphins, that serotonin, that oxytocin, making them feel loved and wanted and desired. Not always going for penetrative sex, just, finding pleasure zones in your body, rediscovering what might feel good for you, like the inside of your arms or the back of your neck or a
Yes.
massage, and just trying to connect with each other in a different way, which will eventually, and potentially lead to much higher quality sex um, after that.
Oh, I love all of what you've just said. And I think it's just that whole, we talked about the mental load earlier, didn't we? And
Yeah,
and as
yeah,
you know, Sarah, men and women think very differently about sex. Men get a regular supply of testosterone pretty much every hour
yeah,
into their body. So they're ready
mm,
anytime, night or day.
yeah.
Whereas for us, I always joke and say, when the postman's been and you've been out and they had a package to deliver and they just dropped one of those cards through.
Yeah,
that's really more like the system we're running on, isn't it?
Yeah.
During particularly perimenopause and menopause, and so you can start the day. I often joke as well and say, like, have you ever been in the kitchen and you flip the kettle on and you might think, couldn't mind a little bit of pleasure and intimacy.
Yes.
Something happens, like that person walks in the room, does something, breathes in a funny way, says something, spills something, and then it's like it's the last thing. The kettle's just finishing boiling, and it's like I
Yeah.
don't actually want him anywhere near me right
Yeah.
now,
Yeah.
and we can feel like that, and again, it's that whole mental load thing, isn't it? It's like it can feel for partners like, God, you never know when's going to be the right time type thing. And that's because we're carrying a lot of that mental load. So, like you said brilliantly before, sharing those tasks, more equality in the relationship, not waiting to be asked. Like, if you can see it needs doing, crack on, and
Yeah.
don't forget to round and don't expect a round of applause after the fact that you've done it. It's about
Yeah.
sharing that mental load, understanding she's changing, and understanding men will also change too, won't they? With age-related testosterone decline. So everyone's changing, and it's having that confidence to go, let's go together on this, let's travel together. And I certainly found that, I was perimenopausal for 16 years. I found it so hard. I just could not concentrate. I was a first-time mum, a 2-year-old in tow. You can imagine
Yeah.
intimacy was not a
No.
priority. It was there, but it just wasn't the priority that it once was. So
Mm.
I really resonate with everything that you're saying. And sometimes it's about that. I think we fear what we'll lose if we say something, but I know that so many women say to me, I hijack situations of intimacy,
Yeah.
usually because if I have been intimate, it is painful, it is sore. Next thing I get a urinary tract infection, it's like, oh my God, I just so don't want
Yeah.
that. And so
Yeah.
even if there's those little breakthrough moments where you do, people often say to me, I create some drama so we don't
Yeah.
have to. And
Yeah.
so if you are watching this and noticing there's a bit of that, maybe that could be an inroad for you to maybe bring up the conversation. Sorry, were you going to say something, Sarah?
I was just going to say yes, and it's really sad because, the divorce rate at this age is really high as well. And when you talked about, connections with people, being able to talk about this in a safe space is so critical.
Yeah.
You don't want to be spending your life shouting. It's not nice for anybody in the house to hear arguments and, see people unhappy and like you say, women avoiding sexual intimacy, then, instead of just having that conversation, so people know that actually it's not about them. It's not that they don't love you or that you're useless, or it's just that actually this is a change and you have to navigate it together.
Yes, I really love that because yes, we have, a lot of us are having children later. We both talked about, our children, going off to university, and we're imprinting all the time.
Yes.
Teenagers are bright people
Yes.
and they are absorbing a lot. And so we want them to absorb that right, that helpful character reference, which is around what do good relationships look like? Well, mostly look like people talking things out and working it
Yes.
working it through. So, but when we know that isn't the case, I think, the link between neuroticism, mental health, and increased suicide risk amongst women is alarming. I mean, that 45 to 64. I mean, we have seen some high profile cases in the news, haven't we?
Yeah.
People's lives just splashed across the newspaper in hard, bold print, as if that's the
Yeah.
sum total. I mean, it's so much more than that. I mean, in your view, what early interventions could actually make a difference before crisis point is reached? So if you're able to touch on that neuroticism, mental health, and sadly that increased suicide.
Yeah. And for me, this was just such an alarming figure. I think we don't even acknowledge this. For me, when I did the first study, that then led to the second and the third study. So they were relying on each other's results. And for me, this was just like, what the heck is happening here? What are we not doing as a society and as medical practitioners? What are we missing that is so massive that women don't have a safe space to come and talk? And
Mm.
sexuality is one of those things. It had such a massive impact on your self-confidence, your sense of self, your self-worth. And of course, there's intersections of, empty nest syndrome potentially, marriage breakdown, not feeling competent and confident at work. There's so many different elements, but this big gap, this void where all of these women are falling into crisis is just horrific.
Did you have
And
any
so,
do you have any numbers, Sarah? Sorry to interrupt you there. Or do you have any sort of like anything you can
I
sort
mean,
of
it was the Office of National Statistics. The data's on there. I haven't got the exact
No, no, that's okay, but it's obviously
rate.
shocking enough.
Yeah, but it's consistently that the increased risk for this group of women between the age of 45 and 50, 64 is the highest across the whole female lifespan.
Wow.
So, it's just a horrific statistic.
Yes.
And for me, I think as a midwife, something that became apparent, which we, of course, I know that kind of pelvic floor injury or birth trauma of some sort will have a long impact. Of course, I know that. But I hadn't actually, because we're in this work stream of kind of going to work, do your job to the best of your ability, come home, go in again and do it again. Because we're working in silos, we don't see the bigger picture. And so the impact of birth trauma and unresolved birth trauma or pelvic injury, pelvic floor injury, um, lots of women brought that up when we discussed it in the research to say that actually this was an ongoing thing from childbirth. Um, so building those, going back to a resource toolbox, identifying these women much earlier. And like you said, women are having babies at a later age. So,
Mm.
you know, capturing this, during smear tests, at postnatal check-ins, doing a psychosexual assessment and asking the questions so they know that there is a consistent narrative in society that we respect that your sexual well-being is important to you. So building that resource box of the HERO acronym, building that hope. Um, what I found in the third study is that introducing it was a small study, so that would need to be developed, but there was indicative evidence that writing positively about positive sexual experiences, remembering times they felt loved, cherished, um, trying to focus on those positive things, built um, that positive psychology. Um, Having group sessions available to women where they can come and talk in a safe space about their sexual well-being, um, and being able to know that when they go to somebody for help, that they're going to be listened to, they're going to be believed, they're going to have a clear framework of, support and intervention. That we are asking those open questions because we talk about abuse. Um, Again, it's an intersectional issue that we ask these questions and tick a box, and then we don't ask again. And we ask in such a way that is, it's measured. It's not looking at the whole woman. When I
But
ask the question, I ask, "Are you safe and happy at home?"
yeah,
Which then
yeah, bring
develops that answer. And I think we need to be asking that question consistently throughout the women's lifespan, really. I mean, we should be asking teenagers about this. We should be asking, you know, women then coming for their first smear. We should be asking women during pregnancy and postnatal periods. We should be observing. We should be, translating this not just in healthcare, but in education, in coaching, we need to be making sure that narrative is consistently applied across professions. So that women know that socially this is unacceptable, that they feel in such a crisis point that they can't reach out for help.
Yeah, that is huge, Sarah. I mean, and I do think as someone who found every medical interaction triggering
Mm.
and a degree of trauma for me still now, all these years later,
Yeah.
I don't think we can just rattle off these questions without asking, are you safe and happy? And actually, is it okay to ask you these questions? Me asking you these questions, it's important for us to understand, but actually, I need to understand, how this might make you feel. We need doctors and specialists to be trauma informed. Categorically, I really believe that. Because I think sometimes we can do a lot of harm because sometimes when you're not asked the questions, when you don't feel someone has that empathy or someone has that experience, it can just be trauma inducing. You can leave another appointment feeling like, oh my gosh, that scab was peeled right back off, and now
Yeah,
I'm back to square one. Um,
yeah,
I was going to ask you because those are so important. I was going to ask you because I don't want to assume you talked about birth trauma and pelvic floor injury. For people watching, what sort of things might come under that? I've obviously heard of birth trauma, but unresolved pelvic floor injury. Can you give us some examples so that people might go, actually, light bulb moment. That's what's happened to me.
yeah. So, during vaginal birth, and most often when it's like an instrumental delivery, so with
Yeah,
forceps or ventouse,
yeah.
that women experience pelvic floor injury. So that's a first degree, second degree, third degree, or fourth degree tear. They can cause like skin irritations where the suture have been, nerve pain in the perineum. So that's in and around the vagina, around the bottom area. Um, right up to women being doubly incontinent or needing stoma surgery. So, I mean, it's massive. And I
It's
think,
huge.
again, we ask about, we have a tick box as midwives. I mean, personally, I go beyond the tick box, but
Yes.
there is a tick box and it says, are you passing urine? Are you opening your bowels? We don't really go into, um, how sex might feel after having a baby. We don't go into what you might experience with pelvic floor, how you need to, there's much more of a movement right now about pelvic floor, improvement. We shouldn't have adverts where we have young incontinent women with
No,
pads. We shouldn't
no,
have adverts like this.
no.
We should be, this is discouraging. This is a normal. We need to be talking to women again, taking away the embarrassment of talking about incontinence, about painful perineum, about painful sex after having a baby. We need to be talking about it because we don't actually know how many women are suffering from this. We know that birth trauma in general, 1 in 4 women are experiencing this, and that can be from a, you know what is trauma to one woman? It could be the way somebody spoke to you. It could be the fact that somebody's done a vaginal examination without asking proper consent. It could be, that you have had, again, like childhood experiences of sexual abuse. We don't really go into that. Um, and there's so many women who carry that package all the way through their life. And so there's just so much we can do to improve the way we work with women. But first of all, it's opening that space so they feel able to talk about their experiences without judgment, without blame, because the whole defensive practice, legal situation, healthcare systems are scared to ask these questions. Um, and I think we don't spend enough time with women is the ultimate thing. The first visit I see women when they've had their baby is quite often the next day now because women go in, have their baby, and they're pushed out straight away, or they've had a home birth and I'm back there the next day. And I spend about an hour just debriefing that birth experience for them.
Yeah, amazing.
And because they've had that hour to go, actually, this is how I felt. No, God, I can't really remember what happened there, but let's put the jigsaw puzzle pieces together because the partner remembers, or I remember, and we can build that picture and it makes sense to the woman. I give them the opportunity then to write down what they remember and what they've experienced and come back with questions the next time. And because they've had that space and time to talk, they, that feels better already. So we don't give women enough time. So, yeah. healthy relationship education, building the toolbox of resources, giving women more time and giving them the opportunity to reclaim their own body, giving
Mm.
them permission to explore their body on their terms, and discover pleasure for themselves first.
Yeah, because one thing I absolutely think needs to change, and I have so much anecdotal evidence of this, Sarah, which I'm about to say, the amount of women that say to me, when I think about that appointment I had, you're called to your doctor, aren't you, after a certain number of weeks, the amount of women that say to me, my husband sat there, coming as moral support, and the first question the doctor asks is, so what type of contraception would you like? We've just we've
Yeah,
sort of just imprinted that
yeah,
on people. And one woman, I'll never ever forget it. She said to me, worse still, that question wasn't directed to me, it was directed to my partner.
wow. Yeah,
Totally
yeah,
invalidating,
yes,
just traumatizing. So coming back almost full circle, if you're in a loving relationship, but you're already struggling because you're thinking it's still painful, I'm not ready. But then we have another character into the scenario who's actually saying, right, it's time. So what would you
yes,
like? I actually would like to just be left alone, actually, thank you. But I don't even have the
yeah,
confidence to say to my partner on a one-to-one, let alone in front of you. So now then we have women then almost being coerced into making decisions that they're just not ready for, and then that's just disempowering.
yes,
So I think that needs a whole shake up, quite personally. It almost to me feels like the only time anyone's ever interested to see me is whether you're going to start me on contraception, stop my contraception, and then restart it.
yeah,
Thereafter, my experience is you're certainly not interested to give me other types of hormones like HRT, so I have to go and do that privately. So I think we do need more care, and it's going
mm.
to take time. Like that's I just wrote down all of those things you just said. You can't do that in a 10-15 minute consultation, can you?
No, no, you can't. You can't. But we really need to, when you were talking about the information we give to men, is that again, that consistent narrative. If men think it's okay because, people have said, oh yeah, what contraception do you want? They're going to think that's normal as well. And so we imprint that right through their lives. And so until somebody says, actually, that's not on, let's look at it from this point and educate them again, then that's only when we can make the difference. And I think, you know, thinking about how we deliver women's health care
Mm,
shouldn't be in disease processes and silos of, okay, you're important to us now
mm.
because it brings money in and it generates kind of income and jobs for the health service. What we need to do is we need to offer healthcare so healthy women can access healthcare at any point in their lives in community-based settings where they
Yes.
have space that they can walk in, drop in at any point, where they have a multitude of professions. They're not always going to be given an appointment right on that day, but they can go in and talk to somebody, that they can be heard, that the space is there for them to explore options, and have that as a healthy woman hub across the
You
country.
just beat me to it. We need to get you as the head of the health hubs, definitely. I spoke to someone from NHS England last week, and
Mm.
my goodness, there's so much to do. I mean, before we get to our last question, I mean, what do you think about the women's health hubs? I mean, we promised them quite a long time ago. I've yet to see one
I
really up
think I
and
think the
running.
concept the concept is great. I mean, I'm old enough now to have worked in sure stop buildings and things that were extremely successful, changing outcomes for families. But and they would have been a great example of how women's health hubs would have transpired now. But again, I fear that because we get a change in government and because priorities change, even since doing my PhD started in 2021, um, I feel like it is a tick box exercise. So they're going, okay, let's have a health hub and see how many smears we can do there and see how many, you know, It's not about the whole woman, it's about your outcomes. And so I don't feel the delivery is being utilized in a way that could be transformative,
I agree.
personally.
I agree because literally last week I'm sort of like going, oh, I think I'm due for a smear, or and I think I'm due for a mammogram.
Yeah.
I kid you not, literally a letter dropped in whilst I'm on holiday going, can you come this week? And if you can't come this week, that's it. And I'm like,
Yeah.
are you kidding me? Like I've
Yeah.
waited 4 years
Mm.
and you're gonna make me like it's this day or no day at all. And it's
Yeah.
just totally inefficient, isn't it? It's like I could take one day out of paid work. I could go to a health hub on a day that suits me, a date that suits them. They've got a scanner there, they've got whatever, whatever, whatever. I could do my MOT a bit like I do my car.
Yeah.
And that's
Yeah.
me good to go for a period of time with checks and balances that I can do myself. But it's like it has become so binary. Like, yeah, you had your mammogram. Yeah, but did anyone tell me actually and stop and teach me how to really examine my
Check
breast?
my
You
breast. Yeah.
squeeze my boob to within an inch of its life between two plates of plastic, but you didn't.
Yeah.
No one's really told me like how to check under my armpit and round my
Yeah.
back and round my neck.
Yeah.
So I agree. I agree with you. I think we need real people to be informing what good looks like, don't we? Like people like you, other amazing people we've had on the show that go, no, 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 that's not going to work in real
Yeah.
practice. That just isn't going to work. And actually looking at some of these questions we're asking, are we being too blunt with some of the questions? Could we be softer with them? Could we have a review? I don't know where we even start with this, but I suppose one of the things that you said throughout this is that it's the silence that's
Yeah.
worrying, isn't it?
Yeah.
Those powerful points, if someone's been abused, that's not often explored during pregnancy. We're just like, oh, she must be happy to have a baby and all the rest of it. We don't know what the backstory is. In your view, what would a more trauma-informed and respectful approach to women's sexual well-being look like throughout their life course, not just menopause? If we were to really go back to basics so that we do no harm, we just make sure it's all okay. What do you think should be in there?
I think we need routine, compassionate inquiry. It's not about, oh yeah, are you suffering from, you know, sexual problems? Have you got a dry vagina tick? Are you dysfunctional in your libido? All of these terms that we use. Um, and in fact, across 34 questions, I think only two touch on sexual well-being. Um, so it's really important that we have that routine, compassionate inquiry about consent, comfort at every reproductive stage, so that we talk to teenagers about actually, this is how your body works. You discover how it feels to be touched in that way first. Expressing that and communicating that confidently with consent, with boundaries, and making sure that young men are involved in that conversation as well.
Yes.
Language that heals and not blames. So replace like why did you put up with that or why did you behave like that with kind of questions like what support would help you feel safe? What support can we put in place to make you feel able to have those conversations with your partner? And have that safe space to hold that woman for a little while until she explores those feelings for herself before she then has that, and then help her build that script that she can translate to a health professional or to a partner. Um, and like we've just talked about, that joined up care, linking kind of sexual health services, mental health services, domestic abuse services, so that women aren't left to kind of navigate that system. We need a comprehensive framework that holds that woman safely until she's found a way out or a way around that situation. That continuity of care, that trust in that person, those professionals, where that it gives you care and choice. So you can
Mm.
choose, you might not want to see. I think in the Scandinavian countries, midwives are placed in women's lives from puberty all the way through to menopause.
Oh, how gorgeous is that?
It's wonderful. It's wonderful. And I think, having that safe space to not have to see GPs, lots of GPs are wonderful and have fantastic relationships with her patients. But in the system, the health system we work in, it's very difficult to give that continuity of care, but also that women feel they may not want to see a GP. Do they need to see a GP? They might
Exactly.
need to see somebody who's just holding that space, who's just boosting their confidence, who's just, you know, letting them find their way. And that's okay as well. And so I think in lots of ways, midwives are placed perfectly to be part of that journey for women. And having that equity, because like you said, in Devon, the services that are available for you may look very different to the services which are available in London, in Northumberland, in
Yeah.
you know, Leeds.
Yeah.
So equality and inclusion, acknowledging that cultural, linguistic, and financial barriers to seeking help as well. So having that equitable service across the country. I did a brief intervention as a volunteer in a women's mosque a couple of years ago, and talking about these topics with those women. At first it was very much like I was going in as a midwife, but there was nobody with babies. So I was dealing with the matriarchs of the society, the
Wow.
community, and I felt that was a really powerful inroad to having that peer support, that community peer support, where they were actually then able to say to me a few weeks in when I'd sat and prayed with them. I went to
Yes.
their mosque. I did sessions with them. But what happened was that matriarchal acceptance of what I was trying to do and that trust I built with them enabled me then to have access to their children, their grandchildren, their nieces, their. But then what we started to do was build a women's health library with them. But it was
Yes.
informed by them, it was led by them. So when we talk about women's health hubs, we talk about patient involvement, but we don't pay them for their time. We don't respect the fact that they're developing our strategy and our services. We need to build them around women. We don't have the answers. Women will tell us what we need to be doing if we ask them. And that's the way forward for me, I think.
Yeah, I love that. Have you heard of the Health Collective? The Health
Yeah.
Collective are run by Dr. Nigat Arif, and she's brilliant, like you. She talks about that power of understanding, being curious, understanding the cultural variances, understanding how people. She talked about actually a breast examination session that she did, and she said it became very obvious the partners were going to be coming along, and so these women who are mostly at home raising the family, they could not leave the house unless their partners were willing to bring them. So the partners came and she said, so had to be really sensitive about how we talked about breast health. So she said she bought a whole load of frozen peas and some pastry. And she was able to put the pea under the pastry and to teach them how to do breast examination. But because of the sensitivity that she'd applied in that way, those women were then able to come by themselves for all subsequent sessions. Other people were willing to take up the slack and do the childcare, do all the arrangements back home, because a lot of these people, they didn't drive, had to get a bus,
Mm,
maybe didn't
mm,
have a mobile phone. So I
mm,
think it's about, so many of us are privileged, but it becomes a bias, and a blind spot for us. We don't actually appreciate how we can get this information to everyone. So I love that. That is a brilliant example of how important it is, that inquiry on all levels and that routine compassionate inquiry. I love that. My friend June, who works with me, will absolutely, she'll go dizzy when she hears that mentioned here, as she's also just completing her PhD in menopause, actually. So
Okay.
I love that. So talking to teenagers, language that heals, joined up care for women, so they have care and choice, not one or the other,
Yeah.
and equity and inclusion for people is fantastic. Oh, so we've asked all our questions, and I always am disappointed to get to the end because I know, like, I'm a talker for sure and definitely an oversharer. So I know we could ask so many more things, but I think what would be quite nice to finish on is if people have loved or like inquisitive about what they've heard you say, there's more coming. So tell us about your book, which is going to be available. It's called Duty to Desire. Tell us a bit about that, Sarah, your inspiration for doing it and whatever you want us to know about that.
Thank you. So, yeah, in this research, obviously the big word that kept coming back was this sense of duty. And when I read the the words of women who spent time to write a journal, it was really heartbreaking. And I have seen across the lifespan from, having teenagers myself, but listening to the narrative that's going on in teenage lives from telephones, from the classroom, there is a huge gap for women to reclaim sexual pleasure for themselves, to understand that their body's changing, they're not dysfunctional or abnormal, that this is an adaptive phase, that whatever pleasure feels, whatever is good pleasure for you is good pleasure for you. It's on nobody else's terms but your own. And so learning to navigate that, re-explore your body, mapping out what is nice, and breaking down those barriers for yourself, because if it has been painful, if there is, historical abuse in has been in your life, that there needs to be a period of, actually, I'm doing this for myself.
Mm.
I have the confidence to navigate what feels good without guilt, and be able to kind of just explore that on my own terms, but then giving you the confidence to express that to whoever you want. So if you want to share that with a partner, if you want to, communicate your needs and your consent and your boundaries, there's tips in there about how to do that, how to develop a script that would just like ask for help from health professionals, being able to build a relationship built on other things other than penetrative sex. So being able to, build those I statements in and think about, okay, I really loved it when we did this. How can we navigate the next stage? And giving people really practical tips and exercises to work through that journey.
Oh, I love
So
that. I
yeah,
absolutely love that because maybe it's that quiet inquiry for someone as a starting point that then gives them the confidence to go, okay, this book is available because other people must be feeling how I feel, so I'm not so alone. Actually, it's
yes,
giving me some things to think about, actually, some discussion points. I mean, it sounds
yeah,
fantastic. It sounds like it's not just for women, actually. It sounds like,
yeah,
actually, for those men that are proactive, are like, as a result of listening to us talk today, going, oh my gosh, this could be what we're experiencing.
yes. It's
Actually,
validating, isn't it? To know that you're not alone, that you're not the only person. Um, so yes. Well, if anybody would like, there'll be a period of free download time, so they're welcome to email me at sarah at drsarahshalhoub at gmail.com. Or yeah, I think I've just given you the wrong email, sorry. It's
okay.
it's Sarah at drsarahshalhoub.com. Um, and then yeah, they're welcome to send me an email and I'll send them the link. Or
Yes.
keep an eye out on LinkedIn.
Yeah, great. So what we'll do is
Yeah.
we'll put the email that you want in the show notes, and
Yeah.
so people can be in touch with you that way. But it sounds like a fantastic book.
Yeah.
I definitely will be downloading a copy of that, and maybe we can get you back actually to specifically talk
Yeah.
about your book. That would be brilliant. So from Duty to
Yeah.
Desire, that will be coming soon. So Sarah, I would love you to give us the summary of our talk today, if you will, in your words. We've talked about sex, silence, selfhood. We said about reclaiming intimacy during your menopause and before or after your menopause. It's up to you. But in summary, what would be the just some of the key things you would like people to take away from today?
Yeah. So sexual well-being is a really important part of your life, and has biological and psychological impacts on how you feel as a woman and how your body responds in certain situations. Um, so it's a really important part of your life. Having open conversations is critical, and having a safe space to do so um, is something that healthcare professionals and society need to take note of, that we need to provide these for women. And that, until you know what pleasure feels like for yourself, you can't then share it with somebody else. So across the lifespan, women should be empowered to know that their body is theirs first and that there are resources available to support them in educating themselves about their own body, about communicating their needs and their boundaries with others, and that, as healthcare systems, we need to be thinking about how we support women to do that.
I love that. That is fantastic. And yeah, what a powerful, particularly that last point, empowering women to know their body is theirs first.
Yeah,
That's like, yes,
yeah.
I love that. Thank you. That's
You're
absolutely
so
brilliant.
welcome.
Yeah. Oh my gosh. So I just knew you would be a fantastic guest. So don't just take my word for it. If this has sparked your interest, you want to know more, I really encourage you to look at Sarah's research, get that book because you'll probably be glad you did. And so will, everyone around you. I think we benefit when we feel more confident. Everyone seems to benefit around us, and women tend to be the barometer in the family. We are the predictors of how things roll. And so if we're
Yeah.
off kilter, it does show up in other places. So for the moment, Dr. Sarah Chalhoub, thank you so much for your time. I'm really excited to get your book, Duty to Desire. Sounds absolutely wonderful. So please be in touch with Sarah if you would like. But for now, Sarah, thank you so much.
Thank you so much.